So by way of introduction, I'm Justin Semstrott. I'm an accident and emergency physician in the U.S. and have been an ocean lifeguard since 1996. I'm the founder, executive director of Lifeguards Without Borders. So I have no financial conflicts to disclose. Some of the feedback that I've received from similar presentations, there's graphic videos and still images of both fatal and non-fatal drowning patients, and that is something that some people find disturbing. And we're going to be talking about the pre-hospital treatment of drowning. This should not supplant your local medical direction and your local protocols that you should follow. And if what is presented is different than what you're doing, then hopefully it should stimulate discussion with your leadership more so than you changing your practice style based on one presentation. So if you can't really tell what's going on here, this is actually the first known documentation of a drowning resuscitation. There was a big battle in Aleppo, Syria on the Orontes River, and it was documented here in 1237 BC with the great, presumably the prince or the king of Aleppo, being held upside down by two of his lieutenants to drain the water from his lungs. It was unsuccessful, and unfortunately it's an idea that has persisted through today in drowning resuscitation. In the Far East, which was intellectually separate from us in the West, there was still this idea that we needed to warm these patients and that smoke had some sort of properties and that we needed to drain the water from the lungs. And the one on the bottom right there over the ox was done in the American West as well. If somebody went unconscious at a saloon, you would throw them over a horse and gallop them in a circle in a chest compression-y, Heimlich-y, something that was better than the nothing available at the time. Our friends on the other end of the world in New Zealand did some pretty interesting, groundbreaking work where they actually administered carbon dioxide to their patients, thinking that if the CO2 levels rose, that it would stimulate them to breathe. Obviously, another unsuccessful technique. By far everyone's favorite, this idea that tobacco had stimulating properties, particularly if instilled in the rectum, which is where we come up with the phrase of to blow smoke up someone's rear end as an ineffective measure of something that we do. You can imagine that this was a technically difficult task, and so these are actually tobacco bellows and tobacco enemas so that you can more efficiently blow large volumes of smoke up your patient's rear. So our objectives, we're going to talk about the definition, the emergent pre-hospital management, and the disposition of drowning patients. And unfortunately, some things that we will not have time to cover, you see here, and they will be presented by other speakers. So drowning has recently received its very own chain of survival, and as was so eloquently put by Dr. Spillman in another presentation, that that prevention piece should take up 90% of the picture, and only when that fails should we go further down that chain. And I liken it to fire suppression systems and smoke alarms. We will save far more lives from smoke detectors and sprinkler systems than the most high-tech advances in burn surgery and burn therapy. Same in drowning resuscitation. It's prevention, 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 and only unfortunately when that fails do we have to go to that very last link here, which is resuscitation, which is what we are focusing on. So drowning seems simple, right? Somebody goes in the water and dies. Well, before 2002, there were actually 33 different published definitions of drowning, 20 on drowning and 13 on near drowning. And in 2002, at the World Congress on Drowning, we said, we're going to talk about drowning as a process. That process begins when somebody is underwater experiencing respiratory impairment. At some point, that process is going to result in death. At some point before death, severe, moderate, mild, and hopefully no neurologic morbidity. And it's our job as resuscitationists to interrupt that drowning process and prevent its progression towards death. In accordance with the Utstein or Utstein style of reporting, we agreed that we were going to get rid of all of these terms, and we're going to resuscitate and treat all of our drowning patients regardless of the type of water, fresh water, salt water, the same during the initial resuscitation. And I'll talk about some of these other terms in their historical context as we pass through them. So some of the human side of drowning and the idea of morbidity. This is two families that are represented here, both from the Las Vegas area. On the right there is Brianna. Brianna is a medical student right now. Her and her husband bought a house in Las Vegas that had a swimming pool. They recognized the need and the importance for building a fence around it. They saved up money for several months, and her husband even took off work and took his vacation so that he could install the fence that was set to be delivered. 2 weeks before that occurred, their 13-month-old daughter, Claire, got into the backyard pool and died by drowning. She now runs a nonprofit to provide pool fences for low-income families that can't otherwise afford them, and she does media appearances with other families. There with Austin is his mother, Sierra. Austin has a twin sibling, and they were at a backyard pool party when he was 18 months old, and everyone assumed that everyone else was watching them. He was missing for about 45 minutes before they found him on the bottom of the pool. He has severe neurologic morbidity. He's blind. He's deaf. He has a tracheostomy and a PEG tube for feeding, and this is him at about age 9. Unfortunately, just a few months ago, surrounded by his family, on May 31st, then Austin died after struggling with the consequences and the sequelae of a non-fatal drowning. And this is one of the big reasons why the term near drowning is like nails on the chalkboard for me, because there's nothing near about this. This was a non-fatal drowning that many families deal with these consequences for many years through many doctors' visits and the like, and it's emotionally, financially devastating. And so we really need to speak the same language and talk about it as fatal and non-fatal drowning. I know Dr. Behrens is going to cover the physiology of drowning later, but in the context of the resuscitation, I'm going to talk about it briefly. After the initial breath holding and struggle, most people will go unconscious after a short period of time of 30 to 60 seconds. But you can imagine that brain death isn't going to occur for another minute, for about another 10 minutes afterwards. So we have this unconscious period where there is still functioning brain activity. You may still have a heartbeat and other reflexes during that time. So very little water, less than 30 mLs, actually enters into the lungs. And there's a lot of reflexive swallowing. So at autopsy, you may find a liter or more of water in the stomach, but very, very small volumes of water actually in the lungs. And even in dead bodies recovered from water who have died by drowning at autopsy, typically only have 1 to 2 mLs per kg of water within the lungs. We have to get it out of our heads that drowning is a problem of the lungs filling with water. There's actually very little water that enters into the lungs. The studies that were done that said we should treat salt water different from fresh water because there's going to be electrolyte shifts and hemolysis and volume overload were done by Dr. Modell in the 60s and 70s, where he actually took intubated dogs with a breathing tube down the throat, and put up to 44 mLs per kg down their endotracheal tubes. And none of the dogs that received less than 11 mLs per kg had fluid and electrolyte changes. Again, the salt water, fresh water, we're going to treat them all the same, because the big problem of the drowning patient is that they're not getting oxygen to the brain. Drowning is a brain problem and not a lung problem. That small amount of water, even just that 30 to 50 mLs that enters into the lungs, certainly does cause some problems. It can wash away the surfactant, which causes atelectasis or collapse of the alveoli. And our surfactant is this soapy proteinaceous material that mixed with water. You mix soap and water together and shake it up, and what do you get? You get foam, right, which is pulmonary edema, essentially, that comes up and can complicate it. Remember, our alveoli are only one cell layer thick, so as that droplet of water touches that one alveolus, it may cause it to rupture, and you're no longer getting gas exchange. You get hypoxic vasoconstriction of the vasculature going to the lungs, as well as bronchospasm and inflammation of the medium-sized airways, which can make it difficult to affect ventilations in these patients, even if you're doing everything 100% correct. So drowning is a brain problem with some lung complications, but their primary issue is that they are not getting oxygen to the brain. I thought this was poetic, and I'll let you read it. So while much has been debated and discussed about What's a wet drowning? What's a dry drowning? What's a delayed drowning? What's a secondary drowning? At the end of the day, it doesn't matter. Somebody has been deprived of, their brain has been deprived of oxygen. They may as well have been in outer space. And now, as resuscitationists, we must interrupt that drowning process and get oxygen to the brain, because amongst all this crowded discussion and all this crowded lung physiology that people really enjoy debating, they have one problem. They're not getting oxygen to the brain. So if our cause of death or morbidity is anoxic brain injury, what's our treatment? Get oxygen to the brain. There is a wonder drug in the treatment of drowning patients. It is called oxygen. So this is the only graph in the entire presentation, and it's my favorite graph in all of medicine, and I use it for everything. At its most fundamental level, this is a dose-response curve. If we take medication like paracetamol or acetaminophen, a standard dose is 650 milligrams. This says if I take 1 milligram of paracetamol or acetaminophen, I get no response. And then as we come up, I'll gradually get more and more response. And then if I take 1,000,000 milligrams, other than having liver damage, I'm not going to get any more response out of it. But I like to think of every disease process in medicine as a continuum from alive and well to dead. At some point, there is a very rapid progression towards dead. And once you are dead, you can't be any more dead. One of the things that I love about accident and emergency and pre-hospital medicine is that it's not my job to get everyone back to alive and well. Just like you saw in Austin's case, some people never get back to alive and well. It is only my job as the pre-hospital provider to halt the progression towards dead, interrupt their drowning process as quickly as possible and as soon as possible. And if you can get them going back the other way, even just a small amount, then you are doing a phenomenal job. And suffice it to say, if it takes to go from zero and normal to brain dead in 10 minutes of our drowning patient, if we interrupt their drowning process now instead of 45, 60, or 90 seconds from now, then they have a better chance at a functional neurologic outcome. This is data from the drowning resuscitation centers in Rio de Janeiro, where they are actually, the fire department is a branch of the military and the lifeguards are a branch of the fire department, and they have physician, nurse, physician, paramedic staffed ambulances and ICU level care at the lifeguard stations. So regardless of the location of the drowning patients, they are often taken to the lifeguard stations where they are attended by a physician. And so they have tremendous experience in dealing with these drowning patients. So of nearly 42,000 rescues during that time frame, the vast majority are treated and released at the scene. But of those that died, how do we predict who needs additional assistance? And I draw your attention here to the center column, which is the percentage of people in each category that died. And rather than fixate on the grades, because Dr. Spillman himself will be discussing this later, if you look at those numbers, 0, 0.5%, 5%, 20%, 45%, 93%, you can imagine that if we put those on a graph, it would look exactly like that first graph that I showed you, that there is a rapid progression towards death. And as we draw our attention here to the grade 4, they have a large amount of foam in their upper airways and they're hypotensive, as defined by not having a radial pulse. Why are they hypotensive? Because they don't have oxygen, right? This isn't a diabetic, hypertensive, renal failure, lung cancer patient that just had a brain transplant on Coumadin, right? This is a very simple, typically otherwise healthy person who has been starved of oxygen and needs oxygen. And the way I look at this is your natural progression of your drowning patient. If you give them oxygen, they get better and they get a blood pressure back. If you don't, then they stop breathing. When they stop breathing, then they go into cardiopulmonary arrest. So this, to me, looks like the natural progression of your drowning patient, or the natural history of your drowning patient. This is Maya Gabeira. Maya is a professional big wave surfer out of Brazil. She was just dropped off by her partner Carlos on the jet ski, and as she's dropping in on this 20-meter wave, she wipes out, which we'll see again in slow-mo. So Olympic quality athlete, professional big wave surfer, they drop in and they do this all the time. They practice these rescues and these pickups. She is wearing a life jacket, and while this is certainly a big wipeout, one thing that complicated this is as she fell, she broke her ankle. She actually shattered her distal fibula as she hit the water. So here we see her struggling. Carlos comes around to pick her up. He's actually going to hit her in the chest with the sled, which is what they normally do. Every other time they perform this rescue, she would grab on right there. He realizes something's wrong, but another wave is coming, so he has to get out of the impact zone. She's held down for about another 30 seconds before he can come back around, realizes something is wrong and reaches down to pick her up, but she's unable to grab, but she holds on to the tow rope. Right? He can't go any faster because she's going to fall off. He can't go any slower because the wave comes, and now she is unconscious, unresponsive right here. She has respiratory impairment as a result of submersion or immersion in the water. She is drowning. So Carlos comes back around to pick her up. He's saying that we are in waist deep water, but we're getting hit by 5 meters of white water, and he continues to get her up onto the shore. So in the subsequent interview, when he pulls Maya up onto the beach, he starts doing chest compression only CPR. Said that he's took a class and that you no longer have to do mouth to mouth as part of CPR anymore. So that's actually Carlos straddling over Maya right there, and the person at her head is Nuno Oliveira. Nuno is a Portuguese lifeguard who was just hired on by Red Bull as an extra. So we're going to shift away from Maya for a moment and take this to be another hypothetical patient, and we'll come back to Maya's course and outcome momentarily. But transitioning to a hypothetical patient, you've just pulled your patient from the ocean. Their airway is open, but they have a lot of foam. They're breathing very fast and very shallow. They're starting to get tired. Their heart rate is rapid. Their blood pressure is getting weak. So what is our critical action, right? We already talked about why is their blood pressure getting low? Because they don't have oxygen. We need to focus on the airway with ventilation and oxygenation. And it can't be overstated enough how important it is to start basic. Start with the basics. If all you have is mouth to mouth, start with mouth to mouth. If all you have is a bag valve mask, then start with that. For those of you in developed systems, going straight to endotracheal intubation or rapid sequence induction can be a fatal maneuver for the patient. A lot of these, particularly those of you in urban EMS systems, this may be the only time that you resuscitate a 3-year-old from a full arrest that looks exactly like your 4-year-old that was just pulled from a swimming pool without a fence, just like the one that's at your house right now. So these can be very emotionally difficult. A lot of these patients have airway obstruction from foam, sand, mud, McDonald's. Did a similar presentation for an EMS system at a large urban center, and they shared a story of a 4-year-old backyard pool party that was pulled out from drowning, was pulseless and apneic, and they had a lot of difficulty clearing the airway because he had eaten so many hot dogs and cake that as this was coming back up, it was too thick for the suction, but too mushy for the forceps to try and maneuver. So the airway can be very difficult to manage from that standpoint. Even if you're doing everything 100% correct, it can be difficult to overcome the decreased compliance of the lungs. A large percentage of these patients will vomit. From an Australian study, it's nearly 90%, which can really make the management difficult. If there's anything that you guys take from this presentation, I want it to be a fundamental understanding of this. The American Heart Association, ILCOR, Australian Resuscitation Council, European Resuscitation Council, CPR guidelines that we all look to as gospel and know and love are written by cardiologists to save out-of-hospital witnessed VFib, VTAC arrest patients. Everything else is a special case. So take, for example, me. I'm 65 years old. I smoke 2 packs a day. I have my yolk-only omelet with my pound of bacon in the morning before going to Walmart. And as I arrive at Walmart, I suddenly collapse. Why? Because I've gone into ventricular fibrillation or ventricular tachycardia as a result of having poor heart health. For those of you that are UFC or Brazilian Jiu-Jitsu fans, if you take a world-class athlete like a Brazilian Jiu-Jitsu fighter and you put them in a choke that occludes both carotid arteries, they go unconscious after about 5 seconds. So a world-class athlete with no blood flow to the brain is unconscious in about 5 seconds. Now go back to our 65-year-old with a poor heart at Walmart. Just a few seconds of not getting blood flow to the brain from VFib or VTAC, and they are going to go unconscious. They will still have several minutes, 4 to 6 minutes of oxygen still within the blood and within the physiological dead space within the lungs. So the focus should be on compressions, compressions, compressions. Circulate the blood that's already there. But even the best chest compression is only going to give them about 25% of their cardiac output. So we need to get a defibrillator on them and shock them so that we can get them back into a perfusing rhythm so they can pump their own blood to the brain. Then they're going to go to the hospital, potentially therapeutic hypothermia, cath lab, long-term lifestyle modifications, and the entire downstream effects from there. The focus should be on getting a defibrillator on them and doing chest compressions. Now I'm me, otherwise healthy, 34-year-old guy. I'm out surfing and I get trapped underwater. My oxygen saturation starts to drop, 90, 60, 40, 20, 0. At some point, my heart runs out of enough oxygen and circulating epinephrine, adrenaline, to keep beating. But I still have enough circulating oxygen and adrenaline that the cells of the heart are firing off electrical signals that can be picked up on a monitor. This is pulseless electrical activity. And then at some point, I run out of enough oxygen substrate for even that, and then I have the proverbial flat line, asystole. So you pull me out of the water, and what's the first thing that you want to do? Right? Not chest compressions, as many of you would answer and have been taught. Your chest compressions are only going to circulate 25% of the 0 that I was circulating just fine before you arrived. The focus must be on the airway. If you start chest compressions without first giving oxygen, then you are trying to start a car with an empty tank. You have to refill the tank first. So the European Resuscitation Council guidelines are currently for giving 5 immediate rescue breaths. Every other council worldwide advocates for 2, I believe as a matter of simplicity, so as not to make the guidelines any different. But you must reverse the hypoxia. You must interrupt their drowning process by providing oxygen to the brain as soon as you encounter your drowning patient. It becomes a matter of academic discussion of, do I do my chest compressions first and then my ventilations, or my ventilations and my chest compressions? And at the end of the day, it doesn't matter. Because if you start with chest compressions and that delays giving the breath an additional 15 seconds, we don't know that that's necessarily going to make a difference in the outcome. But where it matters is if you're doing compression-only CPR. Compression-only CPR is absolutely incorrect. So in cardiac causes of basic and advanced life support, the heart stops. You need to circulate the oxygen that's already there as a temporizing measure till defibrillation. CAB, or continuous chest compressions. Drowning, kids, trauma, everything except witnessed VFib, VTAC out of hospital arrests. The heart stops because there's no oxygen in the blood, and we need to continue with our ABC paradigm. At least at the American Heart Association, this is a little frustrating because here it is in black and white. Unfortunately, this text does not appear in the instructor or the student manuals for when these courses are taught. So this nuance is lost on many. So as soon as Nuno started doing mouth-to-mouth, there was a discussion back and forth in the heat of the moment, and certainly not to discredit either of the rescuers, as to whether or not mouth-to-mouth was needed, because the discussion was we need to just do chest compressions, just do chest compressions. But as soon as Nuno gave Maya a few breaths, then she started breathing a little on her own, and she actually tweeted this picture just 4 hours after arriving at the hospital. And we would expect that just based on the short amount of time that she was unconscious, that she still had circulating oxygen and that she still had a strong blood pressure, and so she would have been in the drowning grade that only carried a 5% mortality. And here she was just before hospital discharge, 6 hours later. She tweeted this picture of her ankle fracture approximately 1 month later at follow-up. And to tell you how absolutely insane some of these pro big wave surfers are, Carlos actually went back out surfing after she left the hospital and caught what was arguably considered to be the largest wave ever surfed at 33 meters. So in-water resuscitation, for those of you that are aquatic rescue professionals and proficient and trained in this, then they have a higher chance of survival. For those of you that are not, this is a technically difficult task. It only benefits the patient that is apneic but still has a pulse. If they don't have a pulse, they need to be removed from the water immediately because you can't perform chest compressions in the water. If they're over 55 and they've had a primary cardiac arrest while in the water, and that's the reason that you're having to rescue them, in-water resuscitation is not for them. They need to be removed immediately from the water so that you can do your circulation and get your defibrillator on them. For the rest of the world, this is the best evidence that we have that shows the sooner we interrupt their drowning process, the better chance they have at a neurologically intact survival. And while there's a lot of discussion amongst agencies who use and don't use in-water resuscitation, it is the best evidence that we have that says the sooner we interrupt their drowning process, the better chance they have at a neurologically intact survival. And they actually make specific devices. I don't have any commercial interest in any of them, but for those agencies that do use in-water resuscitation, don't use the masks with a paper filter. They make ones with a mechanical filter. It seems silly, but many of the agencies that I work with and that I speak to have never considered that before. So if you are going to incorporate in-water resuscitation, then you need to plan and train appropriately for it. These special considerations will be covered by other speakers later today, so I won't discuss them now. 5 minutes. Thanks. So we're briefly going to watch a couple of videos. I don't know the context of this video. It was found online as is, but it demonstrates a couple of points. One is the Heimlich maneuver. This is something that Dr. Heimlich really advocated for, his maneuver as a cure for asthma, cystic fibrosis, drowning, as well as foreign body airway obstructions. And it is something that has persisted, and it makes sense. If you think that drowning is because somebody is full of water and you squeeze them and water shoots out, it makes you feel as though you're doing some good. It is not. You see here she has foam coming from the airway, and he's actually pouring water to try and clear the foam from her upper airways. So the idea of the foam in these drowning patients, again, we just have this small volume of water that is coming up and is going to continue coming up. And you take a small volume of water, mix it with soap and shake it up, and it's going to produce large volumes of foam. If you spend time aggressively suctioning in the pre-hospital setting this foam, you can spend the rest of their life suctioning them, and it's going to keep on coming. So in our patients that have foam, it goes against everything you've ever learned as a pre-hospital provider that you need to clear the airway. If it's frank water or vomit that comes up, of course, suction it and clear the airway. But if it's just this foam that's coming up, you can just bag it back down. It's just pulmonary edema. We will deal with it when they get to the hospital because right now they are acutely dying of a lack of oxygen to the brain. So I need you to resuscitate their brain, because if you bring them to the emergency department with dry lungs and a dead brain, that's not a salvageable patient. But if you bring them to the emergency department with an intact brain, and wet lungs, we can work around that. In some centers, we can bypass the lungs completely and put them on devices. Once we get definitive airway control, we can do deeper and other types of suctioning. This is the last video that we'll show. And it, again, is an unsuccessful resuscitation in the initial phases, but you see this copious amount of foam that's coming up, and these well-intentioned bystanders just want to do something. And so they're pumping her stomach to try and get this out. So what I advocate for a drowning treatment algorithm is, as soon as you encounter your drowning patient, if you have a bag valve mask or a bag valve resuscitator, then immediately just start providing bag mask ventilations to your patient. Even if you're not hooked up to oxygen yet, that's okay. The oxygen concentration in room air now is better than 100% oxygen provided 2, 3, or 5 minutes from now. If you don't have equipment, then you're going to immediately start with mouth-to-mouth resuscitation. If your patient reaches up and grabs your hand while you're trying to use the bag mask resuscitator, then you can de-escalate, use a non-rebreather, use a simple face mask, or whatever other equipment is available. We all agree that this patient needs advanced airway intervention. We all agree that she is in very bad shape. However, if you try and start with the advanced maneuvers, then that is not the best chance for survival. You need to start with the basic maneuvers. This is one algorithm that was proposed by Dr. Peter Antevi, who is a pediatric emergency medicine medical director out of South Florida. Again, as soon as you arrive on scene, start your bag mask ventilations, then check for a pulse and determine if you need to compress. Drill is for using an intraosseous device for his specific system, and then consider your epinephrine or your pediatric or adult advanced life support measures. Again, this is not appropriate for everyone, but this is one such system that is used to address the acute phase. 2 minutes. Thanks. So I love collecting old CPR and training manuals, and this one actually came from the Canadian Red Cross in 1962, and which predates what we consider to be modern CPR, and it's train every member of your family in mouth-to-mouth. No need for delay. Start rescue breathing as soon as you reach the victim. Interrupt that drowning process as quickly as possible. You can do it in bed, on the floor, on the street, in a car, in a boat, in the water. Saving time will save more lives. Interrupt their drowning process as quickly as possible. So in closing, really appreciate drowning as a process and not as an outcome. Drowning is a brain problem, not a lung problem. Resuscitate the brain. Interrupt their drowning process. Oxygen, oxygen, oxygen. Don't forget to warm them up. Anticipate that they're going to vomit, but ignore the foam. Don't spend your time suctioning or trying to clear the foam. Really appreciate the hypoxic versus cardiac causes of arrest. The guidelines for the continuous and chest compression only are written for witnessed VFib, VTAC, out-of-hospital cardiac arrest. Drowning is a special case. And all of your symptomatic patients should be taken to advanced care. And with that, I'll be happy to take any questions. Thank you.